Good afternoon, everybody. I'm Matthew Davis. Just a little bit about myself. I've been doing outpatient wound care for almost 6 years now. I'm a certified wound ostomy and continence nurse and a certified foot care nurse as well. Basically, today we're just going to be going over, building granulation with triple helix collagen, which is the goal of, what we're all trying to do here is heal people up and heal them use the quickest way using the best products available on the market. So as you all know, the goal of a good wound care is changing that chronic wound into an acute wound by building, your granular base to promote epithelialization. One way that I feel that we can do this, in a more efficient way is using collagen, and especially triple helix collagen. So today we'll just be going over basics of wound healing, triple helix collagen, uses and function, and then ordering through advanced tissue. So we'll just start, what is collagen's role in wound healing? So we have the 4 stages of wound healing. All wounds follow the 4 phases of tissue repair. Stage number 1, hemostasis. This is the body's natural response to the first, realization of an injury. Then we have the inflammatory stage, the proliferation stage, and the maturation stage. Collagen is actually the only component that is active in all 4 of these phases. Stage 1, hemostasis. It's the basic process which causes bleeding to stop. It's an integral part of the clotting mechanism or clotting cascade of platelets. You get activation, aggregation, and adherence, which equals coagulation. Second phase, the reactive phase, or the inflammatory phase. This is the phase that we actually see a lot of our wounds get stuck in. It's also known as the stuck stage. This is where we have our monocytes or neutrophils and our macrophages. This is where bacteria and debris are removed and the growth factors are released to cause migration and division of cells involved in the proliferative or regenerative phase. This is also where we run into our best friends, or our worst enemies, as we all know working in wound care for a long time, MMPs. These are part of a family of inflammatory cells that give rise to elevated levels of proteases and degrading proteins. The MMPs appear to degrade what we call the extracellular matrix, or the ECM components, the growth factors and the receptors that are essential in healing levels of proteases or degrading proteins. The next phase is the regenerative phase. This is where we actually start growing, stuff back. So we start with granulation. This is what I always like to describe as the raspberry phase, because it looks just like a nice ripe raspberry. You get those nice buds, which is encouraging for all these chronic wounds. When you get to that stage, epithelialization is soon to come. You also get angiogenesis, the growth of new blood vessels. This is why some of this tissue becomes bright red and is oftentimes friable to the touch. What this does, this gives the tissue template, and it promotes the reapplication, adhesion, and maturation of fibroblasts and the proliferation of collagen. It also provides binding sites for the epithelial cells. So this is putting that, that nice bed for the epithelial to grow over. So we hit the epithelialization, which is basically just the body's way of, covering the granulation with tissue. This is where your skin comes in. And collagen's role in this whole process is to provide the bridge for the epithelial cells to cross the wound surface. You also have keratinocyte migration, and then you have cellular differentiation attachment of the epithelium to the dermis. The remodeling phase. This is where collagen kind of plays one of its biggest parts. You have structural organization, which imparts skin, function, and normal appearance. It accelerates the reconstruction of tissue. Wound strength increases with collagen density. It also reduces contraction and scarring. tissue regains its original integrity. One caveat to that is it only really comes back at 80%, after about a year. And then with each injury, it's at a decreased percentage of that. That's why scar tissue is sometimes the hardest tissue to heal. And then the remodeled wound site tissue is never as strong as the original. That's why people with chronic wounds often break down in the same places they've had wounds previously. So where does collagen really come from? As we all know, we all have natural collagen that comes in our bodies, but we can pull from outside sources. These sources can be bovine, porcine, and avian. And basically, what's important for this part is to always ask your patients if they have any cultural or religious beliefs against any type of, porcine or bovine collagen, because some people are kind of objective to that. The collagen from bovine skin is the closest that we can find to human skin. Type 1 collagen from bovine hides is the closest, and it comes within about 5% of that of a human. It's also free of mad cow disease, so you don't have to worry about anything like that. Here we kind of get a good picture of, collagen and its structure and function. In the first picture, to the left we have native collagen, and then next to that, to the right, we have the triple helix collagen intact, and we have the competitor's collagen product. So as you can kind of see, native collagen looks like if you were laying cement like rebar. And then the triple helix collagen, the beauty about that is it's not denatured, and it's not pieces and parts. So the best way that I think to think of this is you look at the competitive product, and it's basically like a mosaic. All in all, it looks like the same product, but it's really just pieces and parts that are basically shredded together to make that product. Whereas triple helix, it's like looking at the original artwork. It's, one complete brushstroke. It's not pieces and parts to make one big picture. So why do we prefer triple helix collagen? Well, it's an advanced wound care product, and it's 100% pure type 1 collagen. It's not denatured, non-hydrolyzed, or non-modified. The beauty about triple helix collagen, it maintains the triple helix structure that's native to the raw bovine collagen. This is where we get into where's a good point to use collagen. Collagen, we're all in that field where we're trying to figure out how can we get these wounds to heal quicker, faster, stronger, and really just provide that basis for the granulation tissue to grow. So the beauty about triple helix, it's biocompatible, so you can really combo it with almost any product that you want on the market. You can use it over bone and tendon. I know this panel is probably from across the country, so depending on your insurance and payer mixes, you don't have access to a lot of advanced products, such as like an Oasis, Dermagraft, Apligraft on outside applications. I know here in Michigan we're very limited to just diabetic foot and venous insufficiency. In other states you can use it on a variety of applications. So here we're limited to what advanced products that we can use on the outside applications. But that's the beauty of collagen. We can really use it on just about any type of wound that we want. So just an example for pressure ulcers. I know here we get these pressure ulcers, and we're trying to always figure out like what our main goal is, and we've been using silver alginates and whatever type of foam that we can use, and we just never seem to be going anywhere. We've done the whole gamut of getting them on an air mattress or an offloading cushion, and now we just can't seem to switch that from that chronic wound back to an acute healing wound. So this is where I really like to use triple helix. The beauty about it, if you have a large, like stage 3 or 4 pressure ulcer, you can order it in a 10-gram bottle, or you can order ropes. They also have ropes for tunneling wounds. But I like the powder because it's easiest to get into a variety of applications. So say I have a stage 4 ischial wound. Basically what I typically do, order the patient's supplies to advanced tissue, and then we apply the triple helix, and then combine that with an alginate, and then some type of foam or absorbative dressing, and then we try and get a 2 to 3 day wear time. I mean, it all depends on drainage, but the beauty about it is that we can have up to once a day dressing change using the triple helix. And what this really does, especially if we have all the pressure off, it really provides that basis to really start a good granulation base. Diabetic foot, as we all know, offloading is truly the key to any diabetic foot ulcer. But the beauty that I use with this, and we'll see at the end, I have a case study here, it can be combined with anything. So say you have a wound, a diabetic foot wound, that's not draining very much. It's dry. You're not sure really what to do. You can take a hydrogel or medical grade honey, mix them together, and that way you'll get your moisture balance plus the effects of the collagen. I've also used them with a polyvinyl alcohol foam. And what that does is it gives that drying agent, to really pull the moisture out of the wound, but donate the collagen at the same time. And with these, we can leave up to 5 to 7 days, depending on what type of cover dressing we use. And typically, depending on how much the patient's walking, or if they're in a total contact cast, we can go the whole week and really get the results from the collagen. Venous stasis or venous insufficiency. As we all know, compression is truly the gold standard of treatment for these patients. If they're not compressed, they're truly really never going to heal. I always combine it with a secondary dressing, and depending on what the patient has, I usually try and push these out to go about once a week under like a Uniboot or a multi-layer compression. But if they have, say, like one of those devices with the Velcro that they have at home, and they can change the dressing each day, I have them with their daily dressing change apply the collagen, a secondary dressing, and then put their compression stocking or that on, and they really get great results with that. Surgical and traumatic, the first thing that we have to do is always eliminate any infection. So if you have a dehisced surgical wound that had like an abscess or some cellulitis, you always want to treat that first. But once you do that, you get left with this wound, and it always doesn't respond to optimal wound care. So what we try and do, especially in the abdomen, if you got somebody with a large abdomen and you're trying to get into tunnels or places that you can't truly see, the triple helix collagen powder, you sprinkle it in, fill up that whole deficit, and then you're getting great contact with the parts of the wound that you can't see. You can also combine this with negative pressure wound therapy or really any other treatment modality. I've had good experience with it under wound vac or negative pressure, where you're getting that granulation, but you're just not getting that response that you hoped for. Maybe you're not getting a great seal, or there's something else going on, but you add the collagen and you really start to see a good beefy granular base. And again, you can change this every 3 days or go a little longer, all depending on the drainage and the patient. This is where advanced tissue comes in. Sometimes it's very hard to stock all these products in an outpatient wound care center and then provide them to the patient. So what we do, we use advanced tissue a lot. So you can order the patient's supplies based on need for that patient. You can order a 10-gram bottle, which is available as long as you provide your treatment note stating the size of the wound and your need, why you need the larger bottle. But the nice thing about the bottle, it has a screw top, so the patient's able to open it up, kind of measure out how much they need for their wound, and then they can close that bottle back up instead of opening a dressing pack and having this piece that gets left out, or they can't really control what's going on with it. They also have a 2x2 collagen square that comes on basically like a non-adherent matrix that you can order from them as well. The beauty about this, the patient can maintain all their dressing changes at home, still follow up with your clinic about once or twice a week. And then the quantity that the patient's received is based on, your orders, if you want a Q day, Q3 days, whatever you want, and then based on the size, length, width, and depth of the wound. So what are the true indications for the triple helix collagen products? It's FDA approved for certain first and second degree burns, which, first you're never really going to use it on, but second degree burns for sure. Cutaneous ulcers, neoplastic, vascular, inflammatory, physical, and infectious processes. Though I always say, if you have an infected wound, get rid of the infection first. Any type of draining wound. Partial and full thickness ulcers. So this is kind of just a few of those questions that we hear a lot, and we're just trying to provide answers. Can the collagen products cause the wound to bleed? Well, collagen, the beauty of collagen, it's naturally hemostatic. So typically, I've used collagen to kind of use as a clotting agent in that wound bed. Say the patient was debrided, we just want to make sure they get a good stop, so we use the collagen to do that. What I think people are seeing a lot after using collagen, they're seeing a great granular base that's oftentimes friable to the touch. So you rub that piece of gauze over and it starts bleeding. It's not gushing blood, but as we all know, if it bleeds, it heals. So typically that light bleeding of the wound bed is a good thing. If triple helix collagen powders are so absorbent, how can they absorb and act as a matrix on the wound bed at the same time? Well, it's still a matrix, whether it's hydrated or not, so it's still providing that structure to the wound bed. Just like we saw in that picture of native collagen, I don't know if you've ever seen anybody pour cement. They throw that steel rebar, or when they're building a road, they put the rebar down, and then they pour the cement over that. It gives it strength. That's exactly what the collagen does in the wound bed. It provides that structure for the tissue to grow into. So even though it's absorbing and getting rid of the fluid, it's still providing the structure. This is something that I've often run across, is this yellow or white fibrin on the wound bed. Is it actually the collagen material? Should it be removed? Should it be debrided? It's kind of a hard judgment call. Excuse me. So the yellow fibrin is due to blood clotting, and it can actually be a growth factor that's present in the wound. The white fibrin can possibly be a protein buildup. If the buildup of the fibrin continues, stop using the triple helix collagen, debride the wound, and see if you can get back to a healthy base. Sometimes it could be a biofilm, but you're really not 100% sure. So you always just want to make sure that you investigate a little further before just piling product and product and product on the wound. The yellow-white fibrin does not always have to be removed. And you'll see that in the case study that we'll be presenting here at the end. So here's our case study. This was a diabetic foot wound right on the great toe, right over the joint. So basically, the patient had osteomyelitis, and we were struggling with how to get this wound to heal. He was a 90-year-old man, very active at the time, but still had this open wound. So as you can see, beginning in December, we see this wound. Kind of you see that yellow fibrin, and we're just really not getting anywhere. It had been like that for roughly a month previous. So we decided to add triple helix, and this is one of those times where we comboed it with active leptospermin honey and a bordered silicone foam. We changed the dressing 3 times a week, and basically what you can see from 12/11 to 12/18, a significant reduction in the wound size with the epithelialization beginning. As you can see in 1224, we get that yellow fibrin again, but the wound size is still smaller than it previously was. 115, so basically, or I'm sorry, 113, you go back and basically the wound's decreased, over 50% in size, and then by February, the wound is 100% healed. The patient was healed, went to Florida for his winter, went back to golfing. We followed up with the patient in May 2013, and then we followed up again in July, and you can see, really the scarring's decreased, the function of that toe is extremely functional. He's had no issues since, which is really kind of a testament to the strong healing potential that triple helix collagen can bring to the wound. That's a very hard area to heal typically. It's thin skin, there's not much tissue. So, this is one that actually surprised me and kind of got me hooked on triple helix because I didn't think we would heal this wound with the osteo and everything that was present, and we had such a great result like this. Basically, if you have any questions, feel free to type them into the chat panel on the screen, and I'll be happy to answer any. In conclusion, triple helix is easy to use both for clinicians and patients. Complete the dressing change using only a non-adherent dressing, so you can use Adaptic or Mepitel or whatever you have in your clinic. It provides the best healing environment. You really get optimal results. Cost-effective. Triple helix on the market is very cost-effective compared to a lot of the other collagens. And it can be used on any type of wound in any stage of the healing process. And then, if you want to contact me or have any questions, these are both of my email addresses. Both of them go to my phone, so I answer them on a regular basis. And if you have any questions, feel free to ask.
He would like to know, you stated yellow fibrin in this product would not be effective, correct?
No, you can use it with yellow fibrin. Sometimes what the yellow fibrin can indicate, you always want to investigate. It depends how thick the yellow fibrin. So if you have like a yellow fibrin base, but you can see kind of like the granulation coming through, I personally continue using the product. If it's a very thick yellow fibrin, you often wonder, is it biofilm? So typically what we would do is just take a curette, kind of investigate, either clean that off, see what's kind of going on underneath. If there's not much going on, we reapply the product.
All right. That's it for today, Matthew.
Okay.
And we thank you so much for your presentation. Thank you, everyone else, for joining us. If there are other questions, they'll show up in our attendance report, and Matthew will respond to you personally. Again, thank you for your time today. Good day.